Hi, good evening, guys. Welcome back to Biomechanical Institute for Orthodontics. And welcome back here on the BOTCH series, an orthodontic damage control lecture series. Again, we're here on our fourth episode, and we thank you for tuning on with our show. So we've been exposed to about 50 to 60,000 people already around the world, with about 100 shares on our videos and about I think it's around 30,000 views or so. And still, there's a lot of demand from those episodes that we have already taken down. But don't worry, you can just send us a message and we can link you up with those episodes. So we're here again tonight, and Adit and I are here to talk about something that is it's a very hot topic around right now, to be honest, and it's something that really just gives a lot more questions. It's something that gives more questions as we practice it, as people are debating around it, and it's basically about the ligation systems and if these passive systems, if they really work. So Adit and I would love to talk about this tonight. We could have a second part to this, but what we want to do is we want to look at evidences. We want to look at our cases. We want to show you our cases and see how we can really apply this, if it really matters, if it really could help us, or if it could botch up our cases. So if you have any questions, just comment down below on the comment section, and we'll try to answer everybody as much as we could. All right.
So good evening, everybody. Thank you all for joining us. And so as Dr. Pao has already introduced us about this session, I'm going to be speaking about the topic. And the topic is, it's based on perspectives. So today's topic is not laid down for anyone. It's about the self-ligation versus the conventional ligation. So we're not going to talk about any particular brand. We're not going to talk about any particular philosophy. But we're going to be talking about, what we're going to be especially talking about is what we are hearing. Is that actually true, or is it false? So today we're going to be actually speaking from an evidence point of view. So today is going to be more like a systematic review or an analysis. More so, and it's also going to be absolutely based on evidence, and you're not going to be seeing many finished cases, because that's not the agenda today. So we're not promoting orthodontic finishing or anything of that sort. We're talking about the evidence revolving around what we hear about these two systems. Okay, so let's begin. As we already know, we've classified our orthodontic screw-ups more onto the technical as well as non-technical screw-up part of it. Now, this particular topic would convene around diagnostic screw-up as well as mechanical screw-up, and it's also non-technical when it comes to social media-based screw-up. Now, why I'm trying to say it is because nowadays the treatment is not treatment-driven. It's more of appliance-driven. I'm sure Dr. Pao would agree with me on this. I've seen so many practitioners go by the fact that they decide on even extraction versus non-extraction based on the appliance they use. So that's not the right way of how we should deal with things. It should be the other way around. We should diagnose it first, and then we should choose what kind of appliance is best suited for that kind of a treatment. So that becomes a diagnostic botch up by itself. Now, mechanical. Why is it mechanical? Because we think that because of the various claims that these self-ligation brackets have around these days, we try to think of it as, oh, we might not need to do the conventional things that we do to probably get a high canine down, or probably to alleviate crowding, and we can just put the brackets in, run the wire and the very light copper night eyes, and it's just going to take care of itself. So that's a mechanical screw up. I mean, which you would actually see after you possibly put in those wires. I mean, you might just push all the teeth out into the bone, out of the bone rather. So non-technical, why is it non-technical? It's probably because we have so influenced by social media these days. As I've already covered this in the last, I think the episode 1, that we see a lot of these beautiful cases being done by key opinion leaders of different brackets, and we see those amazing treatment plans and treatments happening. So we try to replicate those. So what I'm trying to say is reproducibility is one of the most important factors when it comes to learning from others. There's no point if you are not able to reproduce what I am doing. If you're not getting the same results that I am getting, then what's the whole point of me showing you something? So it's very, very important that way. Now there's this very, very interesting quote, and I would like to just read it. Human knowledge is always frail and subject to revision. That should make us humble and exceedingly careful in claiming neither too much nor too little. This was an excellent quote, and this is so true in today's world. Yeah. So now let's get on to self-ligation versus conventional ligation. I'm going to be speaking about it. First, you've already seen about the next two cases. Most of you have already seen those two cases, but I'm just going to run through them to show you what I'm actually talking about. What I'm actually talking about with these two cases is the reproducibility factor. What I have possibly done on one case to get beautiful results was not true when I tried to replicate the same on another case. Okay. Again, let's go on to this case. Everybody has possibly seen this case already, so I'm just going to be running through it. I'm not going to go into the mechanics of it because this is not about the mechanics. Dr. Pao is going to go more into that. I'm going to be talking about the ideology and the diagnosis behind it. You see the heavy amount of crowding that this case had. Most of you had already seen this. Definitely an extraction case, but this particular case did not want extraction. She did not want any kind of screws or any extractions, any third molar extractions, nothing. So I had to go in for a lot of IPR in this particular case. And this was the time when probably Damon brackets were on the hype, and I just gave it a go. I thought I'll just use them. Although I did a lot of IPR sequentially in this case, at the areas of different crowdings, as you can see that, for example, I started off with a little bit of IPR over here and a little bit of IPR over here and all these things in order to not lose anchorage, because if I would have IPR'd all everywhere, I would have just lost anchorage because all the teeth would have probably moved forward and I would have lost the benefit of interproximal reduction. So I had to do a sequential interproximal reduction, used light wires, had a lot of issues with this particular case, especially in terms of controlling the anteroposterior inclination. They flared out, there was an open bite, and I had to do a lot more interproximal reduction. A lot of elastics were used. And finally, I was able to get a decent finish, no doubt. Even the profile, it has gone forward. It has moved forward. The lips have moved forward, but still within the range in terms of patient satisfaction. She was still satisfied with the outcome. As you can see that I've flared the lower incisors quite a bit. The uppers have not flared because I had some good control in terms of elastics and those things. But the lowers, I couldn't control them. They extruded and then they moved forward. So what I'm trying to say is, I'm going to get to the evidence. Now this is about the treatment objective. So I was able to get a decent treatment outcome out of nothing. So this gave me the confidence. Now, with this confidence, I moved on to this case. Now, everybody has probably seen this case as well. So I'm just going to rush through it. I thought I'm going to be able to gain the same amount of space. Looking at those excellent cases on social media, I tried to replicate the same with these cases. And I thought that, yeah, I've seen people opening up spaces out of nothing. So I would be easily able to open up these spaces using open coil springs, which I tried. The initial plan in this particular case was just extracting the 1/4 because I was under the impression that I would be able to open the space by extracting this. This was pretty easy by just placing an open coil spring, and I would be able to expand the lower arch, considering that they're pretty narrow from the word go. So as you can see, the arches seem narrow. Huge buccal corridors were available. So huge buccal corridors was actually one of the taglines with these self-ligation bracket propagators, that, oh, you see buccal corridors, that means that you can expand. And there was no evidence around it. All of these were just anecdotal and probably just spoken for by key opinion leaders. And we as orthodontists, we as learners, were very influenced by such words, and we were under the impression that we could replicate the same. So this is what we're talking about, reproducibility. So I decided to use a very thin wire and placed an implant over here, started to retract the canines just to tip them back a little bit so that I could get some space over here. But as you can see, 5 months passed and absolutely nothing changed. I was not able to move the canine a bit. I did not get any kind of intercanine or intermolar width or increase or anything, although that was unstable, but still I had to expand. I placed this open coil spring over here as well to get some lip bumper effect, but nothing helped. I was expecting a lot of change, considering the fact that the previous patient that you'd seen had tremendous results. I mean, but this case was showing nothing. And then finally, I had to resort to a T loop over here, and I had to get the canines back, and I had to now change my entire treatment objective, because I was not able to control the lower proclination. So I had to extract the lower incisor over here, because I had promised the patient that I wouldn't be extracting any other tooth except for the 1-4. So I couldn't just go and jump the gun and say that I have to extract all 4 premolars in this particular case, which was actually my mistake. So I tried to just convince the patient that I'm going to be extracting 1 lower incisor, and then it should still be okay. I would be able to correct the crowding as well as the inclination of the lower incisors. But as you can see in the third row, even after the extraction of an incisor, I was not able to correct the proclination, because I was not able to get the desired amount of expansion that I probably thought I would achieve. Yeah, so now there was a situation where the midline was moving, because I was trying to move this particular canine here, and I was getting this lateral incisor out, and the force of this coming out pushed these 3 to the right. And finally, the midline moved a lot to the right. Now I had no space on the left to correct it, so I had to extract a premolar, as you can see over here. So now I told him that I have to extract tooth number 2-4, and he agreed to that. And finally, I used some indirect anchorage, got it back. I used anchorage from the upper screws onto the lower canines in order to get them back as well. And finally, when I was still not able to control the inclination, I went into round wires with some closing loops to give some differential moments over there to tip the teeth back. And finally, I was in a position to get a decent inclination of the upper and lower incisors. So as you can see, it's a hard task. And the mistake I made was going appliance driven. I thought that I'm going to be using this particular bracket, and this is going to give me the desired results. So that is the mistake over here. I should have diagnosed this case differently and then decided which appliance was to be used in this particular case. So now, given a chance, I would never treat these cases in such a way. What I'm trying to say is the factor of reproducibility. It does not depend on the appliance. Don't let anyone tell you that, oh, with this particular bracket, with Damon or with other Genius or with any kind of self-lighting bracket, it's very easy to open up spaces, because that is a mistake. It's not a fact. I mean, it's not a fact there. It's a mistake, because you might get that kind of an expansion on one patient, but if you try the same on another patient, it may or may not work. But in my case, it has never worked. So reproducibility factor with me has always been less than 10%. And that's exactly why I have to reconsider, and I have to plan all over again when in cases where I've gone appliance driven from the very beginning. As you can see, this was the finish, not a very ideal finish, but acceptable compared to which I had been through. The third example is this case again, where I had tried the same thing. Definitely, this is an extraction case, right? It's an upper and lower extraction 4x4 case, an open and shut case. But again, I went appliance driven. I placed in the appliance. I thought that I'm going to be able to get the desired amount of expansion or proclination. Because, of course, one thing, let's make one thing very clear, that no amount of transverse expansion is going to accommodate enough space to correct anterior-posterior issues, right? So let's not get into that aspect of it. If someone tells you that, oh, you can expand and then gain space to push the lips back, it's absolutely foolish. Because of the Ricketts law, right? I mean, 1 mm on the canine would give you an arch length increase of about 1 millimeter. It's about 100% over there. But as and when it goes posterior, the amount of arch length increase reduces considerably. But again, in this particular case, I was able to get a desired decent outcome when you look at it. But the profile has proclined, definitely. But then again, now it's a question of whether or not the patient likes it. Stability is another question altogether. But yes, as you can see, the upper incisors over here have proclined in the superimpositions. The lowers have not proclined much, but still, in this particular case, I was able to get or able to alleviate the crowding. The second case that I showed you, I wasn't able to do that. I waited for about a year and nothing happened. So what I'm trying to say again is you can't use the same appliance on all patients and expect a same or similar outcome. It's not going to happen. It's a question of reproducibility, and that depends on many other factors, like the bone physiology, the patient, the sex, the anatomy, or the amount of buccal bone available, the pre-inclination of your teeth, the tongue size, and many other factors. So it's not only about a particular appliance that we're going to be using or not. So, Pao, are we clear till here?
Yep.
Do you want to add on to something? Do you have a different opinion, outlook?
Well, actually, I like what you said about the appliance first kind of mentality, which would affect us. And I've encountered so many dentists who think this way, and I don't really blame our dentists, but I would rather blame. I won't blame our colleagues. I would blame our manufacturers, because that's how they market it, and that's how they market it aggressively. They would come up to you and tell you that, hey, I have a solution to your problem. You have a class 2 case. Here's the treatment plan, and they don't even know what your diagnosis really is, but they lay down the treatment plan. They say that this is the appliance that is effective for all types, and that's basically a trap where we find ourselves in. So it's very important that we, as doctors, okay, that we shouldn't forget the importance of our diagnosis and then going into which appliance would be the best, and not thinking it that way, as you said. Thinking about, hey, I have an appliance and I have a case that pretty much would possibly fix this, so let me try it. That's not the right way to do it. Yeah. So.
Okay. So absolutely true. And I've just seen we have Dr. Justin Arnold watching along with us, and I'm sure he would agree with this because he aggressively goes against people who go appliance driven. I've seen that in most of his Facebook posts, and he does the right thing as well. So I would inculcate the same kind of habit, and it's a responsibility by key opinion leaders or by manufacturers, and more than that, it is a responsibility by editors of different journals, especially, that are not to fall for such marketing gimmicks and publish the actual data. Because I've seen so many of these articles which are published these days in big journals, which actually really don't make sense. The standards may be going lower, but I think it's a big responsibility because the current orthodontic residents and practitioners, they actually follow the lead. They read a lot of these journals and then they follow them. So I think, yeah,
So
let's move
treat
on.
our patients forward, not backward.
Absolutely, absolutely.
Yeah.
Okay, so the question, will a particular appliance or same mechanics achieve same results in different people? The question that I've been asking in the first few slides. In my experience, the answer is a big fat no. Reproducibility is always a concern with me. I mean, the things that even I do, I'm not probably able to reproduce them in all the cases. These a little too much. Okay, so let's get on to the debate. Now, what are the
Your connection is a little bit faulty.
Is it? Can you hear me?
Yep, now.
Can you hear me now?
Yep, better.
Okay. So is it true extractions? Is it true that it's very easy to level and align with these brackets? Is it true that the space closes really fast? Is it true that there are less anchorage burnouts with such brackets? Is it true that the anterior-posterior inclination or control is better with these brackets? Is it true that the bone actually expands with the teeth or tooth? Are wider smiles more aesthetic? Do they actually go in and provide and produce really light forces as they claim to be? Are they really better for oral hygiene? Do they actually increase patient cooperation? And finally, is there actually a less chair time involved when using these brackets? So we're going to be answering all these questions in this presentation. Again, this is a very, very interesting take. Surrounding the hype around the fixated practitioners of self-ligation brackets exclusively are agreeable words and phrases such as perfection, excellence, best for the patient, less share time, more beautiful, face-driven, high-tech, low force, low friction, and bone adaptation. So these are very big words. Now let's just see whether they are actually evidence-based or absolutely anecdotal. First, let's get to the basics of the stability when it comes to extraction or non-extraction. Now, the claim has been that with the use of self-ligating brackets, the percentage of cases in which we would need to extract teeth are lesser. Now, that depends not on the brackets, that depends on where you're going to put your teeth finally. Now, ideally, your incisors are supposed to be between the FFA point and the FA point. Now, that is going to be the FFA point is somewhere between the superior and the glabella, as you can see over here. Now, this is a very interesting paper which is called 2008 angle. So, however you plan, if you're able to place your incisor particular point, it is aesthetically better for the patient. Coming to stability, lower incisor position and stability. Proclining the lower incisors more than a limit and again affected stability. Expansion in the mandibular arch, especially the intercanine width, is highly unstable. Moving mandible inside sharp in that point, which is 2 millimeter advancement of the lower incisors beyond the apogonion can lead to post-retention lingual collapse of the incisors. Now, these are very, very big papers. Now, for optimal periodontal health, the root must be centered in the alveolus, right? To allow adequate bone on both the sides, that is the labial as well as the lingual surfaces. Now, very interesting paper. Matsumoto et al. Reported that a 50% increase in the probability of the dehiscence when well-positioned lower incisors were advanced 2 millimeters or 8 degrees. So 50% increase in the chances of dehiscence is just absolutely too much. Now, this is one of my cases. As you can see, the girl, the first case that I presented, the lower incisors has moved forward by more than 10 degrees. So that means at some certain point of time, according to Matsumoto, she is supposed to have dehiscence on the lower incisors. So that is really detrimental to the stability. So is it right? I mean, are we doing it the right way? Now, people might claim that, oh, you have probably done this wrong. You could have used low torque brackets on the lowers, you could have used some low torque brackets on the uppers, and that would have maintained the inclination or whatsoever. I do agree with them when it comes to an extraction case, because you have some space to control all these things. But when you absolutely don't have any space, are you trying to tell me that you are going to be able to control the inclination of incisors by just using a thick gauge wire and a low torque bracket without any space? So how are you going to alleviate the crowding in the first place? I mean, there must be some space for the teeth to decrowd. And how is that space going to come? Is it just expansion, or is it also some anteroposterior movement? So the claims that we can absolutely control the anteroposterior movement when it comes to such braces is false and fake. Also, another point and another important factor which was considered as a very important factor when it came to extraction versus non-extraction, was the nasolabial angle. But this paper in the angle, Andrews again, has debunked it. You can clearly see that these two patients over here have a very similar nasolabial angle, but the teeth, positions of the teeth are absolutely different. She has retroclined teeth, low placed, and this lady has proclined teeth, which are proclined and flared. So the nasolabial angle is pretty much the same. So are you going to decide on the extraction or non-extraction just based on nasolabial angle? Doesn't really make much sense. Now, let's get on to the evidence which revolves around extraction or non-extraction coming to such brackets or claims with self-ligation brackets. So the endless enigma of extractions and expansions, do they actually transform an extraction case to a non-extraction case? Dr. Little and Riedel, I mean, these papers that I'm going to be showing you, they're like landmark papers, highly cited, and all of them are they are ultimate truth, because the study has been done in a very, very robust manner. So Dr. Little and Riedel have published a paper, mandibular arch length increase during the mixed dentition, post-retention evaluation and stability. Now, very clearly, he has mentioned over here that lateral cephalometric superimpositions of the mandible has shown variable molar and incisor change after retention. When a particular treatment was done non-extraction, which was actually supposed to be done in an extraction fashion, there was a lot of change in the incisor alignment and the mandibular angle as well. Now, there is another very interesting study which was done by Dr. McNamara and group, which clearly states that there was a study. This study actually compared expansion alone using a rapid maxillary expander on the upper alone to a group which used RME on the upper and a Schwartz on the lower. And they clearly said that even just a rapid maxillary expander on the upper was bound to relapse, and it relapsed quite a bit compared to the group which also expanded the mandible to contain the maxilla as well. So, and definitely the fact that I've already mentioned before, the factors including stability are enough to show that extraction should be a diagnostic factor and should not be a treatment objective. So it should not be appliance driven, that we're going to extract based on this appliance or that appliance. It should be a diagnostic criteria which should be catered for from the very beginning of the case itself. So the next is, next we would talk about appropriately applied extraction treatment does not produce routine adverse effects on profiles. There is another very big claim which says, and I'm sure you would have heard of this as well, everybody listening to me would have heard of this as well, that, oh, if you extract, you might lose the fullness of your lips. And so it's better not to extract. So this theory has been debunked again by these two beautiful papers, Arch Width After Extraction and Non-Extraction Treatment by Janelli. Now, he has very, very clearly put it up that extraction treatment does not result in narrower dental arches compared to non-extraction treatment. So now this goes to say that if we actually think that when we extract, we are going to narrow the arch, it's false. That does not happen. Secondly, we have another very interesting paper by Dr. Bowman, and I had this chance to speak with him, where he he's very aggressive, especially and very clear about the fact which goes around extraction versus non-extraction when it comes to such appliance-driven treatment objectives. So he concluded in his study the aesthetic impact of extraction and non-extraction. And these are two very, very big people. I mean, Dr. Bowman and Dr. Johnson. It is concluded that extraction treatment can produce improved facial aesthetics for many patients who present with some combination of crowding and protrusion. And the third, the paper, an extraction approach to borderline tooth size and arch length problems in patients with satisfactory profiles by Dr. Bowley. Again, their assessment was that they found the mouth area of the patients which were treated by extraction, that they improved and not adversely affected 92% of the time. So that's a very big number to misguide people by saying that if you extract teeth, your arches are going to get narrower. Your buccal corridors are going to be seen much more. You're going to have those black holes. Your smile's not going to be very, very aesthetic. And finally, there's another very important and very, very interesting paper by Dr. Kim, Extraction versus Non-Extraction, Arch Widths and Smile Aesthetics. He concluded that when the arch width of both the groups, that is extraction and non-extractions, were measured from most labial surface of the teeth, the average arch width of both the arches was significantly wider. I mean, he said that the arch width was more wider in the extraction sample. It was about 1.8 millimeters wider than the mandible. Now, the mean aesthetic score and the number of teeth displayed during the smile did not differ between the groups. The results indicate that the arch width is not decreased at a constant arch depth because of extraction treatment, and smile aesthetics are the same in both the groups. So I think these 4 papers written by really, really big guys should be enough to debunk all the factors which go around smile aesthetics and calling it that wider smiles or extraction treatments narrow the arch and they make faces look pretty flatter and all those things. It absolutely depends on your objective and your methodology and your ideal, your final goals of treatment. Do we have any questions, Dr. Pao?
Yes, from Dr. Raid Said. Do you think in a case with a constricted upper arch without crossbite, when we expand the upper arch and simultaneously lower arch, the intercanine width won't increase? And so will it affect the stability? Because most of the recent scholars, including Professor Sato, say that when lower arch is uprighted, the results are highly stable, that some of the scholars say there is no need of a retainer. Your thoughts on that, please?
Okay, so what he's probably saying is when it comes to tipped lower posterior teeth, upright posterior teeth are definitely more stable. But what I'm talking about is particularly the intercanine width, right? Increase in the intercanine width, and I'm going to be citing a paper later which says that there was a 10-year retention study which was done on patients on whom the intercanine width was increased, and the study very clearly pointed out that the intercanine width increased. Yes, it increased in both the groups, that is extraction, non-extraction, self-ligating, as well as conventional brackets. It increased in both these groups, but post 5 years or 6 years, the intercanine width and the lowers, it started to narrow, it started to constrict back to its original intercanine width. So that goes to say that you have to give permanent retention. The minute something goes wrong with your retention, everything falls back into the original. It starts getting back into its original initial arch width. And that's exactly why even Tweed follows the same ideology of not increasing the intercanine width.
All right.
You want to add something to it?
I think if you're going to ask me, we're seeing a lot of these studies, and they're very, very, very strong studies also. But with the human matter, I mean, if we look at it from another perspective, with the human matter, there's just a lot of variables that would go along one individual that would probably be different for another, or maybe even for another race. I think we have to also understand in a deeper perspective the methodologies included in these studies, and also the inclusion and exclusion criteria of these studies, and see how they could apply to certain races or certain individuals that we're treating. So like you said, there's a lot of studies going around internationally as well, and they're being published in big publishing groups. And it's kind of curious, you know, these papers just go through reviews. They go through a lot of standards or processes before they get published. And one would speak for against one another, one would approve of another. And I think, you know, we're, again, just want to affirm everybody that we're not trying to disprove or approve, but we're rather challenging everyone to think from more perspectives than what the manufacturers are just saying that, okay, this is the best treatment for you. And that's what we're trying to debunk here. We're trying to lead people into different avenues of the ways that we can think in regards to how we treat our patients and what we use in our appliances.
I think Dr. Pao is playing a little diplomatic over here, but I, on the other hand, I'm very ruthless when it comes to such topics, and I have a very clear understanding that.
You're a little choppy, Dr. Addis.
Able to do.
We didn't get your last 10 seconds.
Yeah. So what I'm trying to say is that I'm pretty ruthless when it comes to I'm pretty ruthless again when it comes to education or conventional, because for me it is all about the mechanics and probably the biology as well. But it's not blind. I do understand.
Dr. Az, maybe you can just try to fix the connection a little bit. Yep.
Am I back?
Yes, you are. We lost you for a bit.
Okay. So am I back?
Yes.
Okay. So I don't know why I'm saying my internet is. Yeah. So let's get on with it. I was just you just raised a question as to evidence one side, patient perception one side, right? So what do the patient really wants? Such widest smile and all these things. How are we going to deal with that question? So yeah, this paper brings it right onto that topic. So does the buccal corridor really matter? Because I've heard a lot of doctors say that. Very clearly say that, okay, fine, buccal corridor means expansion. It's a very clear indicator for them. Now, this study from Texas, the effects of buccal corridor space on arch form and smile aesthetics. The results are very clear. There was no significant difference in the smile scores related to the buccal corridors for all samples and all viewers. Dentists in particular rated broader arch forms as more aesthetic than untreated arch forms. Orthodontists also rated broader arch forms as more aesthetic than narrow tapered arch forms. Lay people, now you're talking about the patients, lay people showed no preference of arch form. So basically, it is us who have that inside our head, and it's not the patient. And we are trying to put that in the patient's head. Conclusions are this: the study actually demonstrates the presence of the buccal corridor as a non-influential factor in smile aesthetics. However, there are differences in how dentists, orthodontists, and lay people evaluate these particular variables. Now, some very, very interesting study from Turkey, especially smile aesthetics, that is perception and comparison of untreated smiles, conclude with or without extractions, not differentiated by 6 panel of judges. Very interesting conclusions from this study is the arch width and the widening again did not actually make any difference on the smile aesthetics. What actually mattered was the maxillary gingival display. That's the gummy smile was a very definitive variable and factor which actually dealt with when it came on to smile aesthetics. So that were pretty interesting conclusions. So concluding this extraction versus non-extraction when it came to self-ligating or conventional, it's for me, the criteria for non-extraction, that is expansion, are definitely going to be favorable soft tissue profile, good buccal bone thickness rather than just the buccal corridor, lingual tipping of the lower posteriors like Dr. Saeed was mentioning. I would expand, definitely. Upright to retrocline lower incisors because I still have room to procline or upright the lower incisors, which would still keep it within the margins of stability, like Dr. Matsumoto in his study had claimed before. 50% increase in the chances of dehiscence. One more thing is good lip competency. If I have really good lip competency, you can play around with a little bit of proclination and a favorable curve of spee. If you have a very deep curve of spee, you cannot reject or rebut the fact that you might need to extract, because the minute you flatten the curve of spee, your incisors are just going to be flat, and that takes up a lot of space. The factors that you must not consider are that you saw a similar case on Facebook the other day, and so you would do it non-extraction following the same guidelines. The nasolabial angle is very favorable to extract or not extract, as I have already proved to you before that nasolabial angle can be the same in two absolutely different kind of malocclusions. Just because you want to please the patient, or you want to be a non-extractionist or a propagator or a key opinion leader sometime later. So these are the factors that you must not have in mind before deciding whether you're going to go appliance-driven or diagnosis-driven. Now, let's debunk the second very, very important question over here. Are they faster? Now, there are some studies, especially Dr. Miles is an authority on this subject. He has so many papers published, especially when it comes to self-ligation, conventional, the speed and the friction and the aesthetics and all these things. And he has concluded in one of his landmark papers, especially self-ligating versus conventional twin brackets during en masse space closure with sliding mechanics. 13 patients completed the trial. The median rates of tooth movement for smart clip, he used smart clip, were 1.1 millimeter per month, and conventional twin bracket was 1.2 millimeter per month. So that means conventional was a little faster in closing spaces compared to your self-ligating brackets. There was another study published in the AJODO, which has mentioned the comparative assessment of alignment, efficacy, space closure of passive self-ligating brackets versus conventional appliances and Dolsons, which has again clearly stated that the time to initial alignment was significantly shorter for the conventional bracket than for either the active or passive self-ligating brackets. So this is the opposite of in passive or total space closure.
We lost you for the last 10 seconds.
Okay, can you hear me now?
You might want to push your table a little bit closer to your router.
I don't know why it's happening. Okay.
Yep.
Better?
Yep.
Okay, so let's see how long it stays. So
okay.
the next study that I was citing was by a group in the UK who clearly stated that the time to initial alignment was significantly shorter for the conventional brackets than for either the active or passive self-ligating brackets. There was no statistically significant difference in passive, active, or total space closure times among the three brackets that are under investigation. There were some conventional brackets and self-ligating brackets. So this is absolutely opposite to what we are pushed to believe. But at the same time, there is another study by an authority on this subject again, that is a group from Greece by Dr. Eliade. He says again that overall, there is no difference in the time required to correct the mandibular crowding with Damon 2 and conventional brackets was observed. Now, on the other hand, there is this paper in a very reputed journal that's research in clinical orthodontics, self-ligating brackets and treatment efficacy by Dr. Harradin from UK again. Now, according to his research, in matched cases, Damon self-ligating brackets produced statistically and clinically significant reductions in treatment time and number of patients' visits. The reduction in the time required to place and remove ligatures with these self-ligating brackets were modest and little clinical significance. Now, both types of brackets produced good and equivalent reduction in the occlusal irregularity. So now this is a contradicting result. Now, this result goes to say that the time involved with the treatments were severely and significantly reduced when using self-ligating brackets. Now, this paper also answers another very important question. Does the chair side time actually reduce while using self-ligating brackets in comparison to conventional ligature-tied brackets? The answer to that question is no. It does not actually improve any chair side time because the difference was just 9 seconds, which was actually not significant. But yeah, so you have a conflict now in terms of the speed with which the treatment is finished when it comes to self-ligating and conventional. There is another very interesting study, again in the Clinical Orthodontics and Research Journal by Dr. Tanke. This study, the conclusions were, this study demonstrated that Damon's self-ligating system yields faster, better treatment results with fewer appointments for all clinicians. So, damn, that's a really upright conclusion. So, according to him, Damon is way better than anything else. It yields faster, better treatment results with fewer appointments. So there you go. So now
must be sponsored.
No, I wouldn't say that, because the journal is really a reputable journal. So it's a very big journal and interesting one. I'm surprised. But again, this contradicts Dr. Miles' research in all possible ways. So again, I'm going to leave the conclusion up to you when it comes to whether it is faster or not. In my personal experience, let me just tell you anecdotally that I have found that the appointments are lesser, definitely yes, because when I use self-ligating brackets, I call the patients every 6 weeks or 7 weeks, and the copper night wires, they have really nice resilience, and they're very good wires to initially elevate crowding. And as Dr. Pao says, you need to leave the wire inside to cook a bit, and once the wire does its job, you can see good results. And because the forces are very low, and I'm going to get to that, I'm not just saying it, it's an evidence behind it. It gives you very nice crowding correction in the initial stages. But again, when it comes to the regular brackets, conventional brackets, I usually prefer ligature tying them with steel ligatures in the very beginning, and tie the wire really tight into the wings, which give you higher forces compared to the very increased play that you can find between the 013 or 014 copper night and the huge Damon slot, the 028 slot that you have over there. So, of course, the forces are varied and absolutely different. The speed, I wouldn't comment on the speed, because I have almost found similar speed when it comes to leveling alignment. Yes, the forces are way lower with the Damon or self-ligation. But when it comes to space closure, I've actually found no difference. I've in fact seen that the control is much more with conventional brackets. In my idea, it is because of the tight contact that I probably would have with a module or with a ligature that would give me a good first order control and a third order control. I think we lose third order control torque when it comes to using these Damon brackets, because the brackets are just too big when compared to the 019 by 025 wire, which we would probably use for sliding, which would lose out on the third order when you retract. So let's answer another very important question as to what's their effect on incisor inclination. I have had many people tell me, especially when it came to my class 3 or class 2 cases, that you could have used a high torque bracket, you could have used low torque brackets in the incisors, you could have controlled the incisor inclination in different ways. But the issue is, I do understand that it's very easy to control the inclination when you have space at the back. For example, it was an extraction case. Let's talk about an extraction case, and I see my incisors are flared. I can definitely do many things. I can even turn the brackets upside down, or maybe use low torque brackets, because I have space at the back, and I know that space can be utilized to correct the inclination of the front teeth. But what if I really am doing a case non-extraction? So I am not able to fathom the fact that in a non-extraction case, if we just use low torque brackets on the front, I would be able to control the inclination no matter what the crowding is at the back. Because at the end, I need space to alleviate that crowding. So that crowding is either going to go like this or like this. And like this is not stable. And like this is not stable either. So I have to have space at the end of the day. And that space would either come by interproximal reduction or by extractions. So studies like this study, again by Dr. Elias and group from Greece, have put forward a very simple, straightforward conclusion that an alignment-induced increase in the proclination of the mandibular incisors was observed in both conventional and self-ligating. Of course, we usually do have it, and there is no significant difference. So you can't claim that self-ligation probably has a better control over the inclination. Both tend to procline the incisors forward. Now, another paper which was published in the Open Journal of Dentistry from Brazil again concluded the same, on the same lines, that the changes in the maxillary and the mandibular incisor positions were similar. Both had mild protrusion and buccal inclinations, and there was no statistical difference between significant difference between both these groups. Now, this study by Dr. Myers has answered so many questions. It's a very, very interesting study which is published in the Angle Orthodontist. A clinical trial of Damon 2 versus conventional twin brackets during initial alignment. How about the patient discomfort and pop-outs with Damon? They claim that the patient discomfort is way lesser. The pop-outs are also way lesser because of the strong meshwork that is incorporated in the self-ligating or the Damon group. But the results were pretty contradictory. The twin bracket was more uncomfortable. So we're talking about the conventional here. The conventional brackets were more uncomfortable with the initial arch wire. I suppose it is because of the high force involved. Because when we use a conventional bracket, we will have to really stuff the wire in the night eye inside with tight ligatures or modules. That gives the patient a high level of discomfort. However, after 10 weeks, substantially more patients reported discomfort with the Damon 2 brackets when engaging the arch wire. So that means to say that in the initial phases, Damon or self-ligation are better, but when it comes towards the 10-week phase, they become uncomfortable. Now, conventional brackets had basically, now we have something called the irregularity index, right? That is the crowding. You measure how do you measure the crowding? So basically, at both arch wire changes at 10 to 20 weeks, that is when the arch wires were changed in both conventional and the Damon group at 10 to 20 weeks, the conventional bracket had achieved a lower irregularity index than the Damon 2 bracket. That means to say that is better. Now, my theory for that would again be the amount of play involved. I'm sure Dr. Pao would have also noticed that. For example, I mean, I'm sure many of you would have seen those butterfly incisors placed like this, right? And when you have those big bulky brackets, the self-ligating brackets, and you pass an 014 wire or an 016 copper night eye wire, even after about 10 weeks, if you don't change the wire, the teeth are still like this because the brackets are just too bulky. The slot is just too big for that small wire to actually give a deflection, because ortho works, the forces are generated by the deflection on the wire. Now, if the wire itself is going straight, although the teeth are rotated, it's not going to derotate. You need to engage a thicker wire. Now, a thicker wire there would be maybe an 014 by 005 or an 016 by 002, which would cause more pain, because at that one particular point, it's going to engage on the periodontal fibers and it's going to just move the tooth out. So that is going to increase the amount of pain. And that's probably why on wire changes, the Damon, heavier wires, the Damon probably, the pain is much more. And finally, Damon 2 brackets were no better during initial alignment than conventional brackets, as we already discussed. Also, one thing very interesting was that more Damon 2 brackets debonded during the study. Am I audible, Dr. Pao?
We lost you for 5 seconds. For what?
Yeah. So one more very interesting part of this the study was that the Damon 2 brackets debonded more during the study. That is, aside from the claims that their highly improved and high-tech meshwork is going to keep them more stable. So that answers the questions of patient discomfort over here and pop-outs, right? So let's move on to the next question. And the most, this thing, 1 minute. Just give me a minute, please. Yeah. What about the tip and torque? Several investigators and many clinicians have reported difficulties in finishing patients with self-ligating brackets. Particularly, the torque and tip control can be compromised during the greater part of the arch wire in the slot for self-ligating brackets. Now, this is a very clear understanding. Again, it revolves around the size of the slot. The slot is slightly bigger. So what happens is when you engage a wire for finishing or for retraction, you're going to have loss of torque because the wire is not snug fit on the brackets, the slots. So now comes the use of an active or a passive self-ligating bracket. Actives claim to have better torque and tip control, but passives usually have the issues with loss of tip and torque when it comes to the final stages of treatment. And you have many references, as you can see over here, on the same topic. Now, how is rotational play affected? As I mentioned, and I've also given you an example in the last slides, I'm not going to be going into depth with this over here. Dr. Miles in his study has clearly again said that there's a lot of rotation loss, leaving about a 1.8 degrees of rotational play when a 16 by 22 inch arch wire is engaged on a Damon 2 bracket. So that means that minor rotations are very, very hard to correct when it comes to using these bulky slot brackets. You need a snug fit. So now the most important question is, do they actually deliver light forces? And this is the very key to the use of self-ligation itself. So let me answer this question through a paper in the Angle Orthodontist again. Evaluation of frictional resistance of conventional and self-ligating bracket designs using standardized arch wire and dental diapodons. When coupled with small wires like 014, 016, the self-ligating brackets performed better than conventional brackets. Now, why is it? Because for the 014-inch wire on the upper right quadrant, the maximum drawing forces averaged 125 and 810 centinewton for self-ligating and conventional brackets, respectively. So do you see the difference? It's 125 centinewtons compared to 810 centinewtons for conventional brackets. So that means that it is really light on the periodontium. It gives you those light biological forces which are enough to alleviate the crowding, maintaining the biological integrity. So that's where it is good. So now, till now, I think it has two positives. One is the time, which is again a debatable topic, and light forces, which is conclusive. Now, do they really burn out less anchorage? One thing I've heard, and people have asked me a lot, that when we use Damon brackets or when we use brackets, the anchorage compared to conventional brackets, and you wonder, is that even there? I mean, even in my post-graduation, I used to wonder, and I never got a very clear picture to it. But now is when yesterday is when I actually got a very clear picture to it. The reason behind the ideology of lesser anchorage burnout is that when you use a self-ligating for sliding mechanics, the amount of friction is way lesser. That means the amount of force or the reciprocal force on your anchorage unit, that is the molar, is way lesser. And that is why you have lesser anchorage burnout. So that is the philosophy, and that is what was taught to you. Am I cut out, Dr. Pao?
What?
Did you lose me?
You're fine. Maybe about 80% good.
Okay. So the question again was the reason and the logic behind why Damon or self-ligating brackets would lose less anchorage, and that's again anecdotal. That there is no hard evidence to that. But the logic is that sliding mechanics, when using sliding mechanics, self-ligating brackets, the amount of friction is lesser because the slot is bigger. So what happens is the amount of force which is applied on the reciprocal anchorage unit, that's the molar, is lesser because of the less friction. And so the molar loses less anchorage. And that is the logic. But what happens in reality is actually very clear and evident in this paper in the BMC Oral Health, which is a very, very reputed journal. The meta-analysis, and that too, this is a meta-analysis. This is the highest level of evidence that you can have. The meta-analysis from 6 eligible studies showed that no statistical significant difference was observed between the two groups in the rate of canine retraction and loss of antero-posterior anchorage of molars. Also, another very interesting study in the angle orthodontist, treatment time, outcome, anchorage loss comparisons of self-ligating and conventional brackets, concludes that the treatment time and anchorage loss are not influenced by the type of bracket used. So what are they influenced by? I would say that anchorage loss is more influenced by the inclination of the molars, the size of the anchorage segment. Also, it depends on absolutely. So there are very less determinants to anchorage, and it can be more of common sense, because sliding is ligation, by the way, which will bring me to the next topic. So I'm going to clarify this later. Does the kind of ligation actually affect sliding? Now that is the crux of our lecture. The fact is, and this paper, this question means that does ligating it with module or with steel ligatures or with the clips actually affect sliding? The answer is clear in the evidence again, in the angle orthodontist, which clearly says that in a paper, effects of ligation type methods on resistance to sliding of novel orthodontic brackets with second order angulation in dry and wet states. The study clearly states, in the active configuration, binding behavioral patterns of brackets were not influenced by ligation methods. Also, another paper in a very reputed journal, that's a Journal of Orthodontics, clearly says the hypothesis that reducing friction by modifying the bracket ligature interface increases the rate of space closure was not supported. The major determinant of orthodontic tooth movement is probably the individual patient response, which brings me to the very first slide again, that you cannot say that just by reproducing the ligation on different patients, you can expect same amount of space closure. It depends primarily on the patient response, the biological response. And ligation is not a determinant factor for sliding. So you can forget about the factor of anchorage loss or any other thing. I think sliding more depends on the bracket width, the wire width, the configuration of the wire, the material of the wire. Does it have more asperities? Does it have more notching? And the mechanics used, the direction of force. All these are the variables which involve around the determinants of sliding and ligation rather than the brackets itself. So this increased ability of teeth to slide along an arch wire comes at the cost of a reduced range of labiolingual correction, as I mentioned. That is the torque, rotation control for a given wire. Very simple. You might have more sliding because of the less friction, as they claim, but you would definitely have reduced ranges of torque control, rotation control, tip control as well. So, Pao, that was heavy, isn't it?
Yep.
Okay. Questions?
None that I have received so far, but I like the points that you pointed out here. All right, so I think some of these could be actually discussed within common sense. Say, for example, the movement of teeth, whether it's going to be faster. It's not really a matter of what you're using, but rather it's the response of the bone towards the force that the dentist places. So the bone is oblivious to whatever you are placing on the teeth, and it's rather what the bone gets is how many grams of force did you apply, and that's what's going to yield to the movements or not yield in that sense. So yeah, I agree with you. To say that treatments are going to be faster, I have never experienced that these treatments are going to be faster, and to say that it's faster, it's actually highly subjective. I mean, what are the parameters of saying that it's faster? Faster what? Faster between patients or faster within one patient? How fast should the treatment actually be? What is the basis of speed? Are we basing it on the whole treatment? Are we basing it on tooth movements? Are we just because there's lesser friction, just because the slots are bigger? Is it based on the individual tooth movement, or is it based on the treatment as a whole? I think one of the factors that the claims of treating patients faster with SLB is that you don't really get to go into the stage of space consolidation. You usually just stay within the stage of leveling alignment and just go straight into finishing, which is like what is being publicly advocated in social media. But the truth of the matter is that not all patients can be treated with non-extraction treatment. If you treat an Asian who already has a bimax bidental protrusion, and then you're going to use self-ligation, and you have to do extraction either way, I agree with you. There's still not going to be any difference with how you're going to end, because this will be a part of my lecture. The treatments basically with self-ligation, the only advantage of self-ligation would be in the transverse dimension, or maybe in the alignment part. That's where this fourth wall is going to give you an advantage. But then in terms of moving it sagittally, like as you in the last article that you showed, ligation does not really affect the mesial distal movement of the teeth, because the brackets would move along the wire independent of the proximal movement. It doesn't move buccal or lingual.
Absolutely.
What the movement is actually mesial and distal. So there's no the context of a contest here really is zero to begin with. Just the same as the argument in the tissue reaction. If you're loading high, of course you're going to get more resistance there, because you're applying. You're trying to elicit a hyalinization response, and that's going to delay some type of movement. So I like what you pointed out here, that we're basically just clearing out these misnomers that are actually not pointed out when it comes to sitting down in these big events and just listening and saying that things are faster, things are much more beautiful.
Absolutely. True.
And it just makes much more sense.
Yeah. I just have a question by Dr. Vikram. He wants to know whether actually Damon, is there any evidence which claims that Damon probably expands more? So I've kept a slide over here. Does it get the bone along while expanding the arch? Studies have very clearly stated that. Now, this very interesting paper by Dr. Eliades again, self-ligation versus conventional brackets and treatment of mandibular crowding, a prospective clinical trial of treatment duration and dental effects. The results were increased widths associated with crowding correction regardless of bracket groups were noted. So that means, as I've mentioned, both these groups showed increase in the intercanine width. Self-ligating group showed more statistically greater intermolar width increase than the conventional group. Now, the question is it stable? Another very interesting paper published in the Dent Press Journal of Orthodontics by Dr. Almeida concludes there was no significant difference between self-ligating brackets and conventional bracket systems regarding mandibular arch expansion and changes in buccal bone thickness or transversal width of buccal bone. And I would like to point out there was this very, very interesting editorial by Dr. Sheldon Peck. And he was very clearly pointing out that all the propagators, they show the CBCTs. I mean, some of them do show CBCTs, but they're very foggy. They do claim to have some amount of buccal bone around the expanded teeth, just to prove the fact, but these are not clear. So a lot of evidence is still needed. We can't debunk the fact that Damon is falsely claiming such things. There may be, but I would really urge people to come out with CBCT studies to prove very clearly that it's not just dental tipping. It's more of bone along with tooth expansion. Now, the only way you can claim or you can debunk that fact is the myth is by proving with X-rays, with CBCTs, and no matter what, otherwise makes no sense.
Okay. If I may just show my my screen, Dr.
Sure.
Addis, I would just like to share some kind of force, something that I learned.
Definitely. Yeah, because anyways, after that, I'm getting the cases.
Can you just exit your screen, please?
I'm sorry, I forgot. Wait, let me. Why is it so hard? Okay. Yeah.
All right. Okay, this is one of the points that Dr. Giorgio Fiorelli actually was sharing in one of his webinars. Very interesting point, because he was also asked, he doesn't use self-ligating, he uses the statically determinate system, where he does segmental mechanics, but he does a lot of these expansions. And one of the questions that he received was the stability of the bone in that area. And the principle which we could perhaps look at is that if you have a center of resistance, okay, here in the red dot, all right, and you want to move it towards the side, and the force application, okay, or the force level is applied on the coronal site, then you get this tipping. And in this tipping part, basically, you get a lot of stress there on the marginal ridge of your, on the edge of your bone. So on the cervical part. So the interesting point here is that if you attack your center of resistance and you apply a low continuous force, what Dr. Fiorelli shared was that you get to expand this bone and you bring bone along with it through this low type of forces. Now, there would be some cases that would already have a generous amount on the buccal side of the bone, wherein what you're actually doing is uprighting. It's not really a translatory movement towards the buccal. So there would be a difference over there, because the difference would be mainly that if you apply a type of mechanics in one patient, it would not necessarily work for another. And this is where the importance of your CBCTs would fall in determining whether you can or you cannot take into consideration the advantages of these materials. Yeah, that's all.
Yeah, that's pretty interesting. But the hard part with this is okay. Yeah, so the hard part with what you showed is to get to the point of force application. Don't you think so?
Yeah. Yeah.
Because we're nowhere close to the center of resistance. And it's very hard to generate forces at that level, especially from the palatal side, because all our appliances are buccal, isn't it? So it becomes very hard to generate that amount of force when it comes from the palatal. So if we are successful in generating forces from that aspect, I'm sure the entire game would change.
I would agree. It's very difficult. I mean, this transverse or arch development, as they would call it, is a part that is actually considered in the alignment stage, which is at the very start. And in the alignment stage, you're using very thin wires. And if you're trying to develop it at at that time period, it's going to be a challenge, because you're using very thin wires, which would not be able to transform your mechanics moment in the moment sense towards your center of resistance. So I think it will make sense that a statically determinate system would be applied, and that's the only way that you can get the responses. But with a statically indeterminate system, which we are almost all used to, just using a straight wire, this is almost impossible. I think people just get it more into uprighting rather than bodily movement.
True.
Yeah.
Okay. So getting on to the clinical representation of such cases. Now, one thing I would like to just clarify over here is that my usage of self-ligation brackets are absolutely based on it's not on the treatment. It's upon what the patient wants, and of course, I'll be honest over here. The fact is that self-ligation brackets are more expensive than conventional brackets, and at the same time, when usually we have a consult, I give them a particular treatment plan and I give them options, because for me, all the brackets are pretty much the same. It's just that I work for a hospital, so you can understand that a self-ligation bracket costs more, so we charge the patient more. And so for that particular reason is why most of my patients have self-ligation, because when you have your daughter come in and I tell them that, okay, fine, this is the conventional bracket, this is the Damon or the self-ligating bracket, this is a little more expensive because of the fourth wall and the clip, and you don't have to use ligations and all those things. The parent definitely wants the better one. At least cost-wise, because the higher cost gives them a false identification of what's better, and they go for that. And so that's exactly why most of my patients have self-ligating brackets. It's not for the treatment. It's or appliance-driven ortho. It's just because of the fact that they choose the higher option, and it's as simple as that. So this particular case, again, came into the office, and she's pretty young. She has a good, decent profile, good amount of crowding. As you can see that I have very little space over here to get this particular lateral incisor out. But in this particular case, I had made a mistake again to not go the extraction way and to go the non-extraction way, looking at different claims from gurus of non-extraction. And I gave it a go, like I gave it a go in the first case in that particular girl. So over here, you can see that I had placed an open coil spring, a really long one, because I didn't want to engage the lateral incisor. You never do in such cases, because that just proclines the lateral incisor way out and pushes the root back onto the canine, and you'll have torque issues. So I wanted to gain some good space. Once I gained good enough space, I engaged the lateral incisor, started getting space for the canine. Finally, I got the canine down as well, and I was waiting for this particular primary tooth to come out and the fives to erupt. And once that happened, I maintained the space with an open coil spring, simultaneously corrected the overjet using class 2 elastics, which definitely proclined the lower incisors forward in this particular case, because that's exactly where the teeth would go. And as you can see, I was able to slowly gain space. Now, what I feel is I could have done the same thing with conventional brackets. I don't see anything that this particular bracket is doing differently that a conventional bracket cannot do. I could do the case similarly using the regular MBT brackets, use the same mechanics, put ligature, steel ligature ties, and get the same amount of correction. So what's the difference? Number one is that the biological response may be better here, because as we have proved already through evidence, that the forces, the drawing forces are 125 centinewtons compared to 810 centinewtons in conventional brackets. And number two is that definitely, if in terms of usage of conventional brackets, the cost would be another factor. She would have spent less. Now, as you can see, I was able to get a decent finish, but the superimpositions will clearly show that I have proclined the lower incisors and the upper incisors, and that is evident in the profile. So now I can hoodwink people as much as possible, saying that no, she's just put on a little fat and the profile is actually not proclined. But the basic truth lies in the ceph and the superimpositions. You can I didn't attach the superimpositions, but yeah, it's very clear and evident in the ceph itself that the incisors have proclined. And you can see the reciprocal effect on the profile as well. she's okay with it, and that's why I'm still okay with it.
We're losing you a little bit, Dr. Adit.
Yeah, which part did you lose out?
No, just at the start of the next patient.
This patient, right?
Yeah. Right.
Yeah. So add anything?
Not being very clear right now.
Okay. So let's go on to the next case. Now this case again, as you can see, moderate amount of crowding on the upper incisor area and a decent profile to begin with. The teeth inclinations are pretty standard. So what I did was in this particular case, I used anterior bite blocks and I used these mild class 2 elastics over here, gained some space, the regular natural way. Now, again, use of a conventional bracket in this particular case may not have made any difference. It's a question of extracting or not to extract. That is the primary concern. So it's more of a diagnostic issue than an appliance issue in these cases. And as you can see, I was able to generate, get good amount of correction of the crowding. And I use the standard torque brackets. I do not use any high or low torque. But you can see the finish also is good. But you can see the change in the IMPA. I changed the IMPA from 88 degrees to 95 degrees. That's about 7 degrees. And again, according to the paper from Matsumoto, he is going to lose his gums probably pretty soon. That's about a 50% chance of him having dehiscence on the incisor area, lower incisor area especially. You can also clearly see that the upper incisors are proclined, but not too much, just by 2 degrees. Yeah, so coming on to the next part is the space closure. Now, again, people have seen this case. It's a case of a bidental protrusion, bimaxillary protrusion, which was treated
Lost you for the past 10 seconds. Hello? Dr. Adit.
Yeah, are you?
Yeah. Your connection is a little poor from the start of this case. So we if you can just go back. Not much. Yeah, Dr. Adit, I think we lost you completely. All right, hold on. So we're just trying to fix our just a little bit of technical difficulties with Dr. Adit. This won't take long. Hold on.
Yeah, I think I'm back.
Yep, you're back. All right.
I switched off and on my Wi-Fi connection again. I hope that helps. Okay, so let's move on with this particular case, and I think many of you have already seen this case again. This is a retreatment case which came in after self-ligation. That is when the dentist proclined all her teeth in order to alleviate the crowding, and so now her chief complaint was that she actually looks like a monkey, and she wanted to get her lips back, correct her profile, and all those things. So definitely extractions were in order. Extracted the first and second bicuspids in the upper. As you can see, the lower molars are absolutely mutilated. They can just fall off anytime. So I can't get any kind of accurate support from them. So I decided to place the buccal shelf and go in for en masse distalization. Again, as I always say, you must take a CBCT in order to rule out the proximity of the distal lingual root to the mylohyoid ridge before attempting any kind of en masse distalization procedure on the lowers especially. Now, as you can see, the brackets are conventional brackets. These are just the regular MBT brackets. Now, as you would have seen on other channels or other papers, most of these procedures are done on self-ligation brackets because of the low force and all those claims. But yeah, what I'm trying to say is that conventional or self-ligation doesn't really matter. You could use the same mechanics on any bracket and you could get the same kind of results. And you can see over here that I was able to distalize the mandibular dentition quite a bit. You can see the change in the profile, that's huge. And you can see the amount of distalization that I achieved on the lower molar, which is more than about 6 millimeters, which is unlike the stereotypic evidence, which claims that you could just distalize for just about 3 millimeters. There are some exceptions in which it is possible. It depends on the anatomy behind the second molar. Again, a similar case, which all of you have seen again, and this is a loss of anchorage case, retreatment case, in which the patient iatrogenically was led up to a situation like this. And I had to use the brackets, which are conventional because the patient was already undergoing treatment for a long time. As you can see, the inclination of all his teeth are really proclined. The roots are right outside the palatal bone. My objectives were to get the lowers in and auto-rotate the mandible, because such mechanics, whenever you use buccal shelf, by the way, the posteriors go down and the anteriors go up and induce a counterclockwise rotation on the mandibular occlusal plane, which is good for the open bite. And as you can see, exactly that's what happened. By the end of distalization, you can see that I was able to generate a counterclockwise rotation of the mandible, which helped me close the open bite. And as and when I got good amount of overjet, I added in the upper brackets and started using light 5x16 elastics from the upper canines onto the lower buccal shelf, because I didn't want to procline the lowers. If I would have used the elastics from the upper canines onto the lower molars, it would have proclined the lower incisors forward again, which I didn't want. So I continued the distalization, and at the same time, I started tipping the upper teeth back, as you can see. Now, this is the stage where I jumped into rectangular night-eye, and here it's on a 19 by 25 stainless steel, and you can see that I've gained good amount of control. What I'm trying to show is not the mechanics over here, it's the use of conventional brackets for even such cases. Most of you would have it etched in your head because of the notions that you see on social media, etc., that self-ligation and buccal shelf and can go with Damon. So, I mean, it's a standard. I think Dr. Pao would also agree with it. Buccal shelf equals Damon with buccal shelf distalization. It's always like that because that's how we see it. What I'm trying to show is that you could use any kind of bracket. You can use even a conventional bracket with modules to get the same desired result. And as you can see, the case was finished. Smile aesthetics have improved, but the case is still a surgical case. The patient did not agree for surgery. And you can see the amount of controlled tipping around the center of resistance of the upper incisor and the retraction and the tipping on the lower incisors as well in this particular case, which is evident in the superimposition. Now, this is a very interesting case, which I would like to point out. I think very few of you would have seen this case. This case is of a young man with a class 3 deep underbite and with a very deep curve of SPE on the lower. Now, this case, this is what makes it hard. The open bites, for me, are fairly easy to correct, but these cases are slightly more challenging because they involve a deep curve of SPE and the lowers are retroclined already. So I hope you understand that any kind of flattening of the curve of SPE would involve me to upright the lower incisors, and that is going to put me into a situation where the underbite increases all the more. Also, another challenge with such cases is that when you correct the anterior crossbite, the incisal display is very, very minimal. Dr. Pao, have you noticed that in these cases? Whenever you jump the bite in such cases, when the patient smiles, you hardly see the incisors more. You have really, really reduced incisal smile displays when you correct such cases of deep underbite class 3s, because you tend to intrude the upper incisors more. A lot, which would reduce their display.
Absolutely.
Yeah, so now you can see the objectives in this case. What I need to do is I need to retract the lower arch. You see that his mandibular angle is pretty flat. The curve of SPE is deep. And as I have mentioned, I'm again going to reiterate, beautiful study by Rosie and team, which moves around the curve of SPE in different skeletal patterns. If you have a deep curve of SPE and you run a flat wire on a high angle, what you would want usually is the lower incisors to go down, intrude, and flatten the curve. That's what you want ideally on a high angle. You don't want the molars to extrude. But unfortunately, when you place a flat wire on a high angle, that's not what happens. What happens is the molars extrude. And so you get a clockwise rotation of the mandible, which is detrimental to a class 2, maybe favorable on a class 3. But on a flat or on a low angle, you want slight amount of uprighting of the posteriors in order to gain the vertical. And you don't want much of intrusion on the lowers. But unfortunately, what happens is that the curve flattens by proclination and intrusion of anteriors rather than any kind of uprighting of the posteriors. So in this case, he was a flat, low angle. And what I did is exactly, I placed bite blocks on the lower anteriors because I didn't want them to extrude. But I wanted this particular segment over here to come up. And so that's exactly what happened. Now what happened is, in a low angle, I want this part to come up. And so I started using elastics in a distal fashion. And you can see that the curve is flattened. And I usually use 2 hooks for distalization because, in my opinion, this is again anecdotal and it's not evidence-based, that I find some kind of a vertical bowing when I use the power chain directly from the buccal shelf over here to this anterior hook. Although the wire is stiff, I still notice that. And also the power chain usually gets into the gums. So to avoid that, I first start with this hook distal, and then later on, I engage it onto this hook. I divide the forces to 150 grams each, cumulatively getting onto about 300 grams per screw to the end. And so you can see over here that from a progression of a very deep curve, I was able to upright the lower incisors and get a good finish on this case. So starting from here, I ended up in upright incisors and a decent finish on this particular class 3. This was not a very easy case, but yeah, if managed well with conventional brackets, I've done that. So now this is just an example as to what I was talking about, the incisal display. Primary concern, especially with post-treatment correcting such incisors, are that you lose incisal display. Like in this case, you can see that I'm jumping the bite over here. I'm using an intrusion arch on the upper. And when I completed my intrusion, you can see that the incisors have gone up and the patient has absolutely lost visibility of her upper incisors. All she shows is the lower incisors. So my solution to this problem is the use of reverse curve night eyes on the upper. I usually start using reverse curve night eyes on the upper in order to extrude the incisors back, down, gain overjet. And there is a possibility that you might create a posterior open bite with the use of posterior, with the elastics, with the reverse curve. But you could use box elastics in order to curb that issue. Now let's go on to another case of heavy crowding, and I'm going to be showing you how I have corrected this case. This case was treated with self-ligation, and a similar crowding was corrected with conventional brackets. And I have used the same mechanics. There is no Damon mechanics used here. So as you can see over here, in any particular case, I would use the same. I've bypassed the teeth that were very difficult to engage. I've used an 016 or 014 thermal niti. I use early elastics not only in conventional, but I use them in self-ligating, but I use them in conventional brackets as well. And this is just in order to get the canines down. Ideally, I would not have engaged this canine. I may have just bypassed this canine and so on. So yeah, now then getting on to the next stages are the regular stages. I mean, it's just placing the rectangular wires and the elastics and all those and the regular stuff. And finally, as you can see, that I was able to get the situation back in control into a decent situation where she is at right now. So what I'm trying to show over here is not the mechanics aspect. What I'm trying to prove here is that I have used the similar kind of mechanics in both conventional as well as in self-ligating to get similar results. Not the same results, but yeah, they're almost the similar results. So I don't vary my mechanics much when it comes to brackets. I use the same mechanics. Now, this is a case with an animal defect. Again, heavy crowding. This were those times where I was really impressed by self-ligating brackets, and I used to do anything with self-ligating brackets, try to get any kind of crowding alleviated. So I placed in the wires, I placed in all these springs in the hope that they would just gain space. Waited, and still nothing happened. And there was a stage where I was just proclining the teeth. I even went into 2-arch wires in order to procline or to alleviate the crowding. As you can see, I've used a heavy overlay, and then I've used an 012 thermal niti to give those light forces. I tried everything, but it didn't happen. And finally, I had to resort to extractions. And as you can see, extractions have helped me out, corrected the inclination of teeth. And I'm in a situation like this. I know he has a very bad animal defect, but I'm sure that after placing the veneers and after getting his teeth in the right order, he's going to get a new life altogether. What I'm trying to show is this case. Now, this case is this monk. He has a very similar malocclusion to the case that I showed you 3 cases back. And I've used the regular conventional brackets on him. Placed mini screws from day 1, extracted day 1, started retraction on a light niti. And as you can see, I've placed the mini screws on the lower. I've started retracting on a heavy wire. And what I realized is once the bite jumped, he had a functional shift to the mandible as well. And so you can see the big mandibular midline shift. So, and I have absolutely no space over here to correct the mandibular midline. So what I decided is to extract the 3rd molars and place this screw, replace it to a buccal shelf. And as you can see till here, yeah, from here, it's a buccal shelf now. And unilateral distalization is on. I'm pulling only on one side to get the midline corrected. As you can see, the midline is severely off here. Getting on, and on here. Again, so this is the final case that I'm trying to show, a case of very, very severe crowding. And as you can see, again, I've started with the same mechanics over here. I've engaged the teeth all over the place. Now, this is a mistake. I would not do this. The question is reproducibility again. I did this on one case. As you can see, such a high canine. I pulled it down with the elastics. It's coming down. And you can see over here that it's already okay in its position. But when you try doing this on other cases, you might not get the same results. You might find that these teeth really extrude, and this particular teeth will go up. You will find a very huge posterior open bite. You will have flaring of the incisors. And this case is going to go from a difficulty index of 4 or 5 to just a 10, which would be very, very difficult to control. So again, what I'm trying to say is you can use mechanics. You can try them out. If they don't work, you have to immediately change, and don't ever think that one mechanics for all is going to work. It's not going to work. So the conclusions of my lecture today are, and this is a very strong conclusion, seasoned orthodontists know well that natural equilibrium or homeostasis wins eventually. So we had better work with nature than dream up a system that works against her. So I hope all of you really take these conclusions seriously. Think for yourself. I'm not gonna give you conclusions on self-ligation versus conventional. It's up to you to decide. For me, it's the biology, the mechanics that matters more than the brackets. I hope it's the same with all of you as well.
I would definitely agree. Thank you, Dr. Adit, for that insights, for those insights. I would definitely agree with everything that Dr. Adit said, and what Dr. Adit did was basically he broke down all of these misnomers or the false advertising, as I would say. You see, as emotional human beings, these manufacturers will always try to hit that part of you and say, like, this is the best, this is the solution. And what we're trying to say here is that not everything that they would say would apply to your case, especially if the races would conflict. We should look at things from an objective manner, and our objective manner would still be through that proper process of the diagnosis, wherein you look at the x-rays, you look at the limitations of your case, and then that's where you assess. I think the main trouble with nowadays is that there's such an abundance of information available. And, if you have if you have a problem that you're treating, and then you look it up in the internet, suddenly all of these would just come in, and you think that, oh, maybe that would shoot into my treatment plan. And that's where what Dr. Adit basically broke down here is that you have to look sharply into the methodology of those studies or of the cases that he showed. Does it apply to yours? Does the methodology of that speaker or the KOL speaking to you, does it apply the same to yours? Do the exclusion criteria of those patients that your KOL had or Dr. Adit had is same with yours in order for you to be able to place it? And this, I think, would really underline the importance of the dentist and basically say that, hey, you're the one in control here. It's not your appliance, or it's not anything that is being claimed upon by this system. Again, what your patients would always feel at the end of the day would be the grams of force that it receives, not the appliance that you place. It won't know it. So it would certainly not give you anything significant in that manner. So let's just answer two questions here. One from Dr. Jose Jacob. What's your take on variable torques on self-ligating? Do you feel it has its advantage? I personally don't. What do you think, Dr. Adit?
I think it has a limited advantage. You need to use those heavy wires in order to get the absolute advantage. You can use a low torque on cases which involve proclination of incisors to maintain the incisal proclination, and you can use high torque where you need to retract and you don't want the incisors to dump. But I would use them very cautiously in extraction cases, especially. I would not use them on non-extraction cases without space, as there is a risk of exposure of root because of the increased and exaggerated torque values when it comes to high and low torque brackets.
I'll definitely agree. If you look into the classification of the torques, the variable torques of this, you're going to see in the manufacturer's instructions that the indications are basically limited only to the leveling and alignment stage, not really to the finishing. And again, in the finishing stage, in the torquing stage, these brackets don't really have that much of a power unless you use those really, really thick wires. Next, from Dr. Corina Netku, where do you insert the buccal shelf to distalize unilateral after you extract the third molar?
I place them in the buccal shelf. That is somewhere right alongside the first and second molar. You can palpate it with your thumb, and you can feel it, and then you can just insert the buccal shelf screw, which is of about 1.8 into 10 millimeters dimension that I use.
Yeah, I use.
And then you can use it unilaterally. The wire is 1925. You can use a single hook, and you can just dislice on one side.
These buccal shelf implants are like they're I don't know, black magic.
Oh, they're saviors. You can see that case. You can see that case. I really screwed up the midline, and I had no space on the right side. So you need to get the third molar out, of course, and then yeah, you can just move it.
I love these buccal shelf implants, but there's a little bit of a curve in terms of studying or starting up using these implants. Definitely, you have to use a CBCT in terms of placement of this, even just localizing on that area where you need to place it, so you would objectively know it. You can't look into this from a panoramic. You can look at this from a periapical radiograph.
More so again, because you want to know that there is some amount of distance you have behind the second molar, and the distal lingual root is not in contact with the mylohyoid ridge already. Or else it's pointless to try to dislice. It won't dislice. It'll just tip the second molar. It won't go back.
Yeah. All right. And final question from Dr. Manas Mukashi. So, Doc, should the third molar should be extracted right away before distalization?
Absolutely. The third molars need to be extracted immediately. It would be better because it would take advantage of the RAP phenomenon. That's the regional acceleratory phenomenon over there, which would induce good amount of translation when it comes to the second molar.
All right. So we have no further questions. Should we wrap up, Dr. Adis?
Yeah, absolutely. I think we should wrap up. And so today's lecture was absolutely more on a review, or a systematic review rather, on all the papers that possibly which get you the evidence on the table. And I hope this clarified most of the doubts in terms of force systems, extractions, non-extractions, arch width, proclination, and everything. So I'm sure the next lecture is going to be great in terms of mechanics when it comes to using self-ligations.
Yeah. So we're not going to follow our usual 3-hour time or 4-hour time. Today's not going to be a marathon. So we're going to make it short. Next week, tune back in. I'll be the one presenting a little bit more on the mechanics and the science of this ligation systems, and hopefully we can enlighten you on its disadvantages and also advantages. So we'll see you again next week. Thank you for tuning in here tonight. This link will be replayable for